So it's interesting, right? We're here at a CSO symposium with a diagnostic device. Most of the discussion is about clinical problems. And that is why I changed the title of my talk to Diagnostic Power is Clinical Power. And the fact is that, old people like me, when Francesco and I were starting refractive surgery 30 years ago, we were little kids, and there were these older guys in the room, but there were no gray-haired experts, right? And now, I guess we are gray-haired experts because the specialty has progressed, and it's progressed through diagnostics. That is how it's progressed. My entire career was based on ultrasound, as you know, and high-frequency ultrasound epithelial measurements, cross-sectional imaging. Thankfully, we now have OCT that came into the field 2015 commercially. So it's the diagnostic power that gives you the confidence to understand complex cases. And it's not a magic trick. It's not someone who's smarter than another surgeon. It's literally, if you have the tools, you will do better. So I'm just going to show a few cases, and I can't go into too much depth because it's basically a 1-hour talk, which I'm giving this afternoon at the booth at 4 o'clock. But essentially, I'm showing you an ordinary pre-op LASIK case, a little bit of depression here, perhaps from a low-riding upper lid, a low myope, 2016 best-corrected 25-year-old. And what I want to do is I want to go through the case the way I would go through the case in the clinic. In other words, I open this, I don't just look at printouts, I open the software. This is the right eye, okay? Now, here's what's interesting, right? You've got your anterior surface, your tangential curvature, and you can see that there's this little steepening above. As you can see, you can right mouse click on this scale and get what's called a normalized scale, so you expand the scale of the epithelium. And you should always normalize the epithelial scale because you're looking for 3-4 micron differences. And if the color scale is set wide, the whole thing is green, even though there are 3 or 4 micron differences. So always normalize the epithelial scale. And as you can see, as I do that, you can see that we now have epithelial depression in a donut pattern in the region where the posterior surface is elevated. And that's what we're looking for when we're screening for keratoconus. The other eye, very similar. You can see that where the posterior surface is raised, that's exactly where the epithelium is thinner with a donut around it. Now, what's interesting is that, the classical keratoconic classifiers all come out normal. But if we go back to the other eye, you see that on the epithelial map, there is a little red exclamation mark. And that's because it's recognizing that the epithelial pattern is not normal, okay? So it's the epithelial pattern that's the most sensitive way of detecting whether there's keratoconus not the topography or back surface tomography necessarily. In our case, what we do, of course, is multimodal imaging according to the Renato Ambrosio doctrine, and we are using the Corvis, and now we know that this cornea is quite stiff, and the TBI is certainly completely normal, so low susceptibility, but on final screen, because a case like this, we escalate to the diagnostic power, and then we go to 1 micron precision on the epithelial maps, and we find that there's actually very, very intense focal thinning of the epithelium in a certain spot in the center, and the COMC calculator, which is an AI calculator, actually classifies this epithelial as keratoconic in both eyes. So, what can I tell you? It's a minus 0.5. If you'd done PRK, you probably would never know what's going on, but I'm just giving you an example. So this is example number 2. Let's see if this one works the way we want it to. So this patient is a suspect keratoconic, even though the best corrected is good and the SIL is low. No one looks at this and says, oh, that's totally normal. Everyone goes, I'm not sure. And that's the way it used to be in the past. Well, now we're in the present, and now we have an MS39. And so now we're going to actually look at the keratoconus screening like this. Now look how it's all green on the epithelium at the top. And now we're going to normalize the scale. Ooh, Christ, that's totally different. Get it? Always normalize the epithelial scale. In fact, you can normalize the back surface as well, and just so that you can see exactly where the points are. And what I do is I'll put the cursor on the maximum point of elevation and check where that corresponds on the map. Because sometimes there might be epithelial thinning, but it's not correspondent with the back surface elevation. And I mean, this one does classify the cornea as borderline because the anterior surface has this large asymmetry. But qualifying that, it could have easily been thickened epithelium, easily, and then it's, not keratoconus at all. But the fact that we have inferior steepening is concerning, right? And we have it in the other eye. Here it shows up without normalization, but it's more obvious in that case, okay? So I'm going to go back to my slides and show you that the Corvis shows a slightly soft cornea, although the TBI is low, the susceptibility to ectasia, when you combine both with the random forest publication of Renatos. On insight scanning, we have 1 micron precision on epithelium, and the CMC calculator says it is normal. So again, sometimes even an expert who's been trying to do this for 30 years is still struggling with information, and my job is to go to as many modes as possible and to develop a clinical impression for myself as to whether I think this is a high-risk case or not, and whether it's defensible if I was wrong. So those are the parameters. Now, I want to move away from keratoconus screening because we can talk about that for a whole hour, but this is a very interesting case because I talked about the MS-39 as being the slit lamp of the 21st century, right? And I have a slit lamp, like a 20th century slit lamp, and next to it I have an MS-39. I go like this with a table, and then I look at the patient's cornea with the 21st century slit lamp. This patient had had LASIK in 2010 with a thin flap by me, but she presented to London. She was from the Middle East. She presented back to London with a 3-year history of eye pain in the right eye. And she had been diagnosed with HSV keratitis. She'd been put on a cyclovir, tablets and creams, and now she stopped everything because she looked up on the label and it said that it could be nephrotoxic, so she didn't want to take it anymore, so she stopped it. And she presented like this. Now, with this history and looking at the cornea, I was thinking, God, is this disciform? I mean, what is this chronic? But then I looked at the epithelium and I was like, whoa, is that zoster? And what is going on here? Okay, so I'm getting a little anxious here. And I'll put the herpes family onto the diagnosis. But I also thought, well, if no one told me anything about this case and I was looking at that, I just go, well, looks like a recurrent erosion. So I put that on the differential and went to the slit lamp of the 21st century. And when you do that, quite simply, there's a mode where you can scan at 10-degree intervals. Yeah, you can scan at 10-degree intervals for 360 degrees, right? All the way around. I'm just sort of rotating it rather quickly, but you can see. So, oh, that's the post-op, sorry. I gave away the, I gave the punchline before the, I'm so bad at telling jokes, you know. Yeah. So you can see that you can scroll through the different images, and this was your instantaneous confidence in what was going on. Instantaneous. Why? Because I have a bullous epithelium, okay? I have a bullous epithelium, and I can see that there's absolutely nothing going on in the deep stroma. Nothing. It's clear as a whistle. And I'm pretty confident that the excess backscatter from here is not scar. Why? Because it was gray all over, but it's only gray in the middle here. And that's because the reflectivity of the beam is higher in the center. So because of that, I'm confident that this is just edema in the stromal component of the flap. So I'm now getting, I now am very confident. I told her I don't think this is herpes, but I took it to the OR, removed all the epithelium, sent it for PCR, no problem, and then did a 25 micron PTK. And I just gave away my, wow moment punchline, but this is what she looked like once she had healed. And that's the same cornea, right? Beautiful. This is a week later, right? Okay. And obviously, first time she hadn't had pain in 3 years. Okay, so, you know, nice case. Do you agree? Yeah, nice case? Okay. Why was she on Timolol? She was a steroid responder, and I think, I don't know. She was on Timolol. I don't know. I don't know. So here's my Vivity case. This is my slit lamp photographs taken in a dark room and then with the flash. So what I'm doing is I'm getting a sort of like a slightly scotopic pupil because it's dark in there, and when I flash, it catches the pupil before it goes down. This is the QOV, which is the validated night vision questionnaire, and this patient had severe symptoms in all categories, and his satisfaction was, out of 1 out of 10, was 0. It's one of those patients. Now, again, I did exactly what you suggested, Francesco, and I went to the Osiris, because that is our diagnostic tool for optics.